Assalamu alaikum everyone. Today's video is a continuation of my previous lecture on congestive cardiac failure. In this video, we will discuss the various types of heart failure. So let's start with the systolic dysfunction. As the name indicates, there is a dysfunction of systolic phase. Means that the heart is unable to contract properly. The problem is in the contractility of the chambers of heart. Because of the problem in the contractility, there is a reduced ejection fraction. That ejection fraction in this case is below 40%, as we know that the normal ejection fraction is above 58%. That's why this is also called heart failure with reduced ejection fraction. In this case, the shape of the heart is dilated, as well as the end diastolic volume is increased in this case, as well as there is more end diastolic pressure, but the ejection fraction is reduced because of the contractility failure. There are various causes of the systolic dysfunction. The most important cause is ischemic heart diseases. This is the most common cause of systolic dysfunction, like angina or myocardial infarction, causes the weakness of the myocardium. That's why there is impaired contractility and leads to systolic dysfunction. The other causes are hypertension, myocarditis, drugs like alcohol and cocaine, infiltrative diseases of the myocardium, and radiation therapy damage the myocardium. Also, some valvular heart diseases, especially the mitral regurgitation. Due to mitral regurgitation, there is a overfilling of the left ventricle, and increased end diastolic volume causes the myocardial causes the weakening of myocardium, due to which there is a systolic dysfunction. So these are the causes of systolic dysfunction, or also called heart failure with reduced ejection fraction. Now come to the diastolic dysfunction. In this case, the ejection fraction is preserved. That's why it is called heart failure with preserved ejection fraction. As the name indicates, there is a dysfunction in the diastolic phase. Means that the heart is unable to relax properly. There is increased stiffness of the chambers of heart. Due to increased stiffness, there is an impaired ventricular filling. Here the end diastolic volume is low, but end diastolic pressure is high. The most important and common cause of diastolic dysfunction or the heart failure with preserved ejection fraction is systemic hypertension. The other causes are valvular diseases like aortic stenosis, that is narrowing of the, or that is incompetent or narrow aortic valve, and mitral stenosis. Also, some causes are restrictive cardiomyopathies like early stages of amyloidosis, in which there is a deposition of a myeloid plaque in the myocardium, and hemochromatosis, that is iron deposition, which damage this myocardium and deposited, due to which it becomes thicker and diastolic dysfunction occur. The other causes are cardiac tamponade, that is blood start accumulating around the chambers of the heart. The other causes are constrictive pericarditis. So all these are the causes of diastolic dysfunction. The most important cause is systemic hypertension. Now come to the high output cardiac failure. In this case, there is no pathology or no abnormalities in the heart, but the oxygen demand of the body tissues is increased. The causes for increased oxygen demand are thyrotoxicosis, that is hyperthyroidism increases the metabolism of the body and increases the oxygen demand of the body tissues. So the workload on the heart is more to fulfill that oxygen demand. Other causes are severe anemia, so decreased oxygen carrying capacity of the blood. In order to fulfill this oxygen demand, the workload on the heart increases, which leads to high output cardiac failure. The other causes of high output cardiac failure are pregnancy, in which there is also increased oxygen demand, and very severe thiamine deficiency. Paget's disease of the bone, in which increased catabolism of the bone and increased bone turnover. So in this case, there is also increased demand for the oxygen. Also AV fistula, that is arteriovenous fistula. Due to arteriovenous fistula, there is a mixing of oxygenated and deoxygenated blood. Due to the mixing, there is decreased oxygen supply to the tissues. That's why which leads to high output cardiac failure, aortic and mitral regurgitation. So this was high output cardiac failure. Now come to the main topic, that is left-sided heart failure. Left-sided heart failure is also called forward failure, because in this case the left ventricle is unable to pump the blood into the aorta properly. That's why it is called forward failure. Now come to the symptoms. Most of the clinical features of the left-sided heart failure are because of the congestion of the pulmonary system. because there is a left ventricular failure, that it is not able to pump the blood into the aorta properly. That's why there is a overfilling of this left ventricle, which leads to the regurgitation or backward flow in the left atrium, and the left atrial pressure increase. As a result, from the left atrium there is a regurgitation of blood into the pulmonary veins, which results in increased hydrostatic pressure in the pulmonary capillaries, which leads to the pulmonary edema. So the lungs becomes heavy and bogus. Now come to the symptoms. As we have discussed previously, that most of the symptoms in the left sided heart failure are because of the pulmonary congestion. The most important symptom is dyspnea or difficulty in breathing. This is because of the pulmonary edema and pulmonary congestion. Patient has difficulty in breathing. Orthopnea means when the patient is in the recumbent position or lying flat, there is more venous return to the heart. Due to more venous return, as well as there is a pulmonary congestion, as we have discussed previously, and more venous return, so increased, it exaggerated the pulmonary edema. So the patient feels dyspneic, or patient has difficulty in breathing. So patient, and it is relieved by changing the position, or by it is relieved by standing. Now come to the next feature, which is paroxysmal nocturnal dyspnea. After 1 to 2 hours of the sound sleep, patient becomes suddenly dyspneic and wakes up and grasping for the oxygen because of the gravity. When the patients lie flat in the or in the recumbent position, especially the edema on the standing position in the as is at the basis of the lungs, but on the lying flat, this edema shifts to the apices as well. So it causes paroxysmal nocturnal dyspnea. Patient becomes dyspneic during the sleep, and it is relieved by taking some pillows behind the head. Other features are nocturnal chronic cough. The reason for this chronic cough is same as that of the orthopnea and PND. Now, the patient may develop the features of confusion and memory impairment. This is because of impaired or reduced blood supply or reduced oxygen supply to the brain in severe cases of heart failure. Other features are fatigue and cold peripheries and decreased blood pressure. These features are because of the forward failure, because this left ventricle is unable to pump the blood into the aorta. That's why decreased oxygen supply and decreased blood supply to the peripheries, so cold peripheries and reduced blood pressure. So these are the symptoms. Now come to the signs of this left sided heart failure. The sign is displaced PMI. PMI means point of maximal impulse. In short, we can say that the apex beat, there is a displacement of the apex beat towards the left side because of the cardiomegaly. And also the most early feature of the left sided heart failure is S3, also called ventricular gallop. This S3 is basically because of the ventricular overfilling, especially when the mitral regurgitation, which causes the left sided heart failure. So due to the ventricular left ventricular overfilling, there is a volume overload, and this S3 is best heard at the site of apex beat by the bell of the stethoscope. So this is very specific and very early sign of left sided heart failure. And this S4 is best heard at the left sternal border. It is because of atrial systole. When this atria contracts against the stiffened ventricles, this S4 sound is produced. It is called atrial gallop, and it is best heard at the by the bell of the stethoscope at the left sternal border. So S3 plus S4, if heard by the stethoscope, these are the important signs of the heart failure. Crackles or crepitations at the bases of lung. There is a crackling sound because of the bases of the lungs can be heard by the stethoscope because of the pulmonary edema or pulmonary congestion. The other features are cardiac wheezing, which is similar to or resembling the asthmatic wheezing, but this patient does not have asthma. Because of the peribronchial edema, there is a narrowing of the bronchioles, which causes the wheezing or whistling sound is produced same as that of the asthma, but it is called cardiac wheezing. It is not asthmatic wheezing. And sometimes there is a dullness on percussion can be appreciated because of the pleural effusion in the lungs. So dull note can be appreciated on the percussion in the left sided heart failure. So all these are the clinical features of left sided heart failure. Now come to the right sided heart failure. The right sided heart failure is also called backward failure because in this case there is a backward pooling of blood into the venous system of the body. That's why it is called backward heart failure. The causes of right sided heart failure are: the most common causes left ventricular failure leads to right-sided heart failure. When there is a left ventricular failure, it causes a regurgitation and congestion of pulmonary system. So there is pulmonary hypertension develops, and this pulmonary hypertension leads to right-sided heart failure. So the most common cause of right-sided heart failure is left ventricular failure or left-sided heart failure. This is the most common cause of right-sided heart failure. The other causes are pulmonary hypertension, pulmonary valve stenosis. Here there is a narrowing, and the tricuspid regurgitation. So these are the causes of right-sided heart failure. Now come to the clinical features. All the features are because of the regurgitation or venous pooling. The JVP distension is the important feature in case of right-sided heart failure. There is a distension of JVP because of the backward pooling of the blood into the superior vena cava and regurgitation into the superior vena cava. So there is a distension of JVP. And also because of the portal congestion, hepatoportal congestion, there is a hepatomegaly as well as splenomegaly. And doctors also sometimes check the hepatojugular reflux. This hepatojugular reflux can be checked by pressing over the right upper quadrant. When the doctor press over the right upper quadrant, this blood, the pooling of blood in the portal system, then move towards the superior vena cava, and there is more distension of the jugular vein. So this is hepatojugular reflux. And also due to the congestion of the venous system, the patient may develop ascites, that is fluid accumulation in the peritoneal cavity, and anasarca. This anasarca is basically a generalized edema. In this case, there is a pericardial effusion, pleural effusion, as well as the edema of the limbs as well. So this is generalized edema. Also the pitting pedal and pre-tibial edema is also important feature, but it is non-specific feature because it also develop in the nephrotic syndrome and the liver problems. But this edema is dependent. When the patient is in the upright position or on the standing position, this edema is in the feet. But when the patient lying flat, this edema shifts on the back side of the patient, and it is pitting edema. So these are the features of right-sided heart failure. If the patient has developed the right-sided heart failure as well as the left-sided heart failure, this is called biventricular failure, and this is also called congestive cardiac failure. Now come to the few criterias of diagnosis of heart failure. The most important is framingham diagnostic criteria for the heart failure. There are some major criterias as well as some minor criterias. If two major criterias are positive, it means that it is diagnostic of heart failure, and if one major criteria and two minor criteria are positive, it is also diagnostic of heart failure. The major criteria for heart failure are paroxysmal nocturnal dyspnea, weight loss of 4.5 kg after the start of treatment, hepatojugular reflux, S3 gallop and crackling sound at the bases of lungs, jugular venous distension, and central venous pressure more than 15 centimeter of the water. This central venous pressure is basically indirect measurement of the right atrial pressure. So cardiomegaly on the chest x-ray, and on the autopsy findings there is a pulmonary edema, cardiomegaly or visceral congestion. If two of all these criteria are positive, if two from all these criteria are positive, it is suggestive of heart failure. The minor criteria are nocturnal cough, means dry cough at night, hepatomegaly, pleural effusion, bilateral ankle edema, exertional dyspnea, vital capacity is reduced because of the pulmonary congestion, and tachycardia when the heart rate is more than 120 beats per minute. So these are the minor criteria. If one major criteria and two minor criteria are positive, it is also diagnostic of heart failure. Now come to the New York Heart Association classification. This classification is important in the management of heart failure. In the class 1, the symptoms appear on vigorous activities. There is no limitation in the daily activities. Patient develops dyspnea or the symptoms of heart failure on vigorous activities like on playing sports. So in the class 2, the symptoms appear on moderate exertion like on climbing the stairs. There is a slight limitation in the daily activities. In class 3, the symptoms or the dyspnea appears on the usual daily activities like combing hairs, like changing the dress and walking across the room. So there is a severe limitation of the daily activities. In class 4, the symptoms appear even at the rest. There is a total limitation of the daily life activities in the class 4. So this was the New York Heart Association classification. So we will discuss the complications, investigation and management of the heart failure in the next video. Thank you so much for watching this video.